Okay, so welcome everyone to the March edition to the MAS seminar series. We are very glad to have you here. Just a note for those who it's their first time joining our seminar series. The purpose of this series is for people in our MAS community to have the opportunity to really share the work that they're doing. So, of course, that extends to students, alumni, and our faculty. So we have the pleasure of having Dr. David Baker here with us today, who is the co-director of our MAS in Population Health Management. So I will kick it over to him to further introduce himself and get started.
Great. Thanks so much, Morgan. Appreciate it. And thanks everyone for joining today. Today, I want to talk a little bit well, first I should say, in addition to my job as adjunct associate professor and co-director of the Population Health Management Program, I also I have a full-time job at LifeBridge Health here in Maryland. And I work there as executive director of population and community health. And really, I want to take today to talk a little bit about some of the work that we've done around population health management and really share some of the practical examples and outcomes that we've seen. So let me just share my screen and, okay. All right, can you see my slides?
Yep, sure can.
Excellent, excellent. So let me go to the next slide and just give you an overview of what I'm going to speak about today. And then, afterwards, welcome your thoughts, your questions and examples that you're doing, either at your healthcare facility or wherever else that you may work. So I want to talk about a little bit about what LifeBridge is, give you a brief overview of our community, and then talk specifically about some sample initiatives, particularly diabetes education and our Healthy Food Access Program, our Care Happens Here mobile unit, and our community pastoral outreach. So a little bit about what LifeBridge Health is. So we are a comprehensive health system based in really central Maryland. So we have 4 hospitals, including Sinai Hospital and Grace Medical Center in Baltimore City, focusing on West Baltimore, as well as Northwest Hospital in Baltimore County and Carroll Hospital in Carroll County, located in Westminster. In addition, we have 7 nursing homes, senior living facility. We employ 13,700 employees. We have 825 employed providers and 2,300 credentialed providers. We also have multiple urgent care sites throughout Maryland. So a little bit about the community that we serve, and I'm going to start with this kind of busy slide. This is an area deprivation index map for the area that we serve, which is again primarily sort of the western side of Baltimore City and Baltimore County. And the area deprivation index is really a composite measure created by the HRSA back about 30 years ago, and then validated at the census block or neighborhood level. And it really shows, and you can kind of see this, it's a composite measure, first of all, of several things, of income, employment, education, housing, and transportation status, really in those communities. So it really addresses a lot of these, social determinants of health and gives you a sense of that community. And this data has been used, it's created by the University of Wisconsin School of Public Health and School of Medicine, and it really allows for research into health policy and allows for decision making on health delivery too, primarily in underserved areas. And to understand this map, first, if you go to the upper right-hand portion of the slide, you'll see a key. And the least disadvantaged block groups are those that are in the darker blues. As you get sort of more toward disadvantage, the map becomes sort of more yellow, orange, and the most disadvantaged block groups are in dark red. And if you look on the map, sort of on the left side of the screen, you see in the lower right side, you see Sinai Hospital in a dark red area. Below that is Grace Medical Center, a freestanding medical center. Toward the center in Randallstown, you see Northwest Hospital. And in the upper left, you see Carroll Hospital in Westminster. And really, all of these areas are in areas of high disadvantage. So a number of studies have been done with the area deprivation index and its relation to healthcare. And you see that the risk of 30-day hospital readmission, if you live in a disadvantaged neighborhood, is similar to having emphysema and worse than having diabetes. So also in addition to this, LifeBridge finished its community health needs assessment, which is something that we're required to do every 3 years to really to take the pulse of our community and get a better understanding of what it considers are its top health concerns and health-related social issues. And this is what we found. So we got surveys back from about 900 to 1,200 respondents in each of our hospital areas. And this is sort of the overall findings. So this is in rank order. For health concerns, we found that they reported high blood pressure and heart disease as number one, followed by diabetes and obesity. Number three was addiction and substance use, followed by mental health, chronic pain and arthritis, and cancer. When you look at health-related social concerns, the number one issue voiced was gun violence and neighborhood safety, followed by healthy foods. Either they can't afford them or they have limited access or knowledge about them, followed by housing problems and homelessness. And then access to health insurance was noted as a problem, and access to the doctor's office. And that was often due to affordability. So with all of that as context, LifeBridge really created sort of our aims around interventions in our community. And our aim is really overall to implement a cohesive and integrated strategy to improve the health status and well-being of our communities that we serve. Specifically, we want to improve access to healthcare where and when needed. We want to identify and respond to needs of special populations, such as those who face health disparities, health inequities, or who are at risk of avoidable hospitalizations. We also want to identify and really address those underlying drivers of poor health. For example, limited access to healthy food, limited access to primary care or health care in their neighborhoods, or limited access to or knowledge of social services. So we recognize that we can keep swatting mosquitoes or we can drain the swamp. And so there's been a lot of study that kind of validates this approach and shows that a targeted focus sort of upstream can really prevent those costly downstream outcomes for hospitals and patients. And these include things like high admissions, avoidable volumes at hospitals, high length of stay, using the emergency department for primary care purposes, poor management of chronic diseases such as diabetes and heart disease, and overall health inequities in our neighborhoods. And on the right side of the screen, you'll see a fairly recent article from 2022 from the Journal of the American Medical Association. And it found that there was an association with the national expansion of insurance coverage for medically tailored meals with hospitalizations and healthcare expenditures. And specifically, it found that their economic evaluation of 6.3 million eligible US adults found that national implementation of medically tailored meals for patients with diet sensitive conditions and activity limitations could potentially be associated with 1.6 million averted hospitalizations and a net cost savings of 13.6 billion annually. So now I want to go into three examples of some of the programs that we've implemented and some of their outcomes that we've seen. And the first one is our Diabetes Education and Healthy Food Access Program, which is a 4-year program funded mostly by rates from the state of Maryland. And before I get too into the details of this program, I just do want to give you some additional background. So the LifeBridge Health hospital service area has some of the highest rates of diabetes morbidity and mortality in the state. And when you couple that with poverty and lack of access to primary care and to healthy food, grocery stores, et cetera, diabetes, prediabetes, and gestational diabetes have worse outcomes and have a quicker progression from prediabetes to a diabetes diagnosis and higher death rates than the state and national averages. And also added to this, we've done surveys in 2024 of LifeBridge hospital inpatients, and they identify that they self-reported that they had 8% of them self-reported that food insecurity was one of their top concerns. So our Diabetes Education and Healthy Food Access Program was really this partnership grant from Maryland's Health Services Cost Review Commission. So we partnered with St. Agnes Hospital, which shares some of the neighborhoods and zip codes that we serve. And the program provides diabetes prevention and management education, and then access to free healthy food for participants who complete at least one class. So we really wanted to make sure people were learning about their chronic disease before we started providing them with food. And this program was structured to target really 4 of our community health improvement priorities, including diabetes, food security and access to healthy food, health and equity, and community health and education. And it was education was provided virtually and in person. And then the participant had access to 8 months of fresh fruits and vegetables, medically tailored meals, often via home delivery or grocery store credits. And it was made available to adults with diabetes who can't otherwise afford or lack access to healthy food. So the program actually ended in December of last year, of 2024. We were able to serve 1,092 community members, and almost 600 of them alone were served during 2024. A little bit about how the program works. So first, we wanted to really make sure that we were promoting the program and that our healthcare providers were aware of it. So for their patients with diabetes, they could recommend this program. We also included, in addition to sort of lunch and learn sessions with clinicians, with endocrinologists, with primary care providers, we had regular announcements in our medical group newsletter. And we have community health and wellness teams that regularly meet with organizations in our service areas, and they distributed program flyers to really acquaint community members with our program and how to kind of access these services. So once we start getting referrals, our healthy food coordinator works with them and explains eligibility criteria, which again include a diabetes diagnosis, willingness to participate in education, and no or limited access to healthy food. Our healthy food coordinator then directs those eligible community members to one of our diabetes educators that we have across our hospitals. And as I said, after completion of that, at least one class, virtually or in person, the participant can enroll in the healthy food access component. And our healthy food program coordinator contacts the program participants who complete education and then helps them select a food partner. The coordinator then sends that referral to the food partner through Maryland's health information exchange. The food partner then alerts the coordinator of the start date of the food delivery program. And these are some of the food partners that we worked with in the community. So Hungry Harvest, Movable Feast, the Food Project, and Meals on Wheels. And again, they either delivered a box of medically tailored meals or fresh fruits and vegetables for 3 months. And that was followed up by, once that portion was completed, the participants had access to up to 5 months of in-store benefits for about $80 of free in-store diabetic-friendly food, including fresh or frozen fruits and vegetables, dairy, eggs, and chicken. We also worked with a group called Tangelo that provided bi-weekly delivery of fruits, vegetables, and grains. All right. So, and after this program had been going on for a while, we wanted to get a sense of its impact. So, we did a survey of 85 participants, and this was in September and through October of 2024. And we asked them several questions. Our kind of main outcome measures were, how is your A1C since your participation in the program? And 88% reported that they saw a 1% or more reduction in their A1C of their blood sugar levels. 62% saw a 2% or more reduction in A1C, and 32% saw a 4% or more A1C reduction. And because this is self-reported, we acknowledge that there could be some reporting bias or other bias. So we also checked with our electronic medical record, and a portion of the participants of this program had been seen by our endocrinologists or primary care doctors, and we had some data on them. And we did find that our data in our EMR aligned with the outcomes that they had reported. So specifically, of the 37 participants we found in Cerner, our EMR, 51% had a 1% or more A1C reduction, 22% had a 2% or more A1C reduction after their participation in the program. We also asked about weight loss, and 82% reported losing at least 2 pounds, 37% lost 11 or more pounds. We also asked about behavior. So we asked about their healthy food consumption. 65% reported eating more fruits and vegetables than before. In terms of behavior changes, we asked them to rank behavior changes since their participation in the program. And that's sort of the number one was they reduced highly processed fast food in their diet, reduced sugary drinks, increased exercise, lost weight, and then regularly tested their blood sugar or regularly used a continuous glucose monitor. We also had a section for them to provide free text responses. And one of our questions was, what parts of this program helped you most? And this is some of the responses that we heard. So the delivery of healthy foods to my home was really helpful since I never learned to drive and do not live close to grocery stores. Being able to speak to a dietitian was helpful. Not worrying about the cost for food versus whether to use that money for medicine. Receiving fresh fruits and vegetables really helped. When I eat fruits and vegetables, I eat less carbohydrates and sweets. The benefit of learning from others and the knowledge of the facilitator. The program helped me to understand the diabetes process better. I'm more mindful of portion control and the best and worst time of day to eat. Having fresh fruits and vegetables helped as opposed to eating canned, which can be unhealthy. I've also lowered my blood pressure, so it helped in more ways than one. And one response was I stopped being depressed. So that's that program. I now want to move into talking a little bit about our mobile unit that we've implemented. And this really started at the beginning of the COVID pandemic. Um, and our aim with our mobile unit is really to kind of address those problems with access to primary care and access to services, healthcare in communities. So our aim, again, improve access to health resources, particularly in underserved communities. And we provide adult services that include partnering with community organizations to improve resident health. So some of the community organizations we partner with in West Baltimore include churches, synagogues, and faith-based organizations, barbershops and salons, senior centers and buildings, libraries and community centers. And prior to development of vaccines for COVID-19, our mobile unit staged multiple screening events in West Baltimore neighborhoods, typically outside. And then after vaccine development, we delivered thousands of vaccines to community residents. Our pediatric wellness mobile service efforts have centered around school-based immunizations and providing wellness screenings and referrals, in addition to students, also to their family members. This is a bit more detail about the Care Happens Here mobile unit, and this is just for fiscal year 24, some of the data. Some of our outreach at churches, schools, and senior buildings. We did 351 screenings at Clergy United for the Transformation of Sandtown, primarily for hypertension, high blood pressure, and heart disease. We provided close to 200 vaccinations at schools. This was a partnership with Baltimore City Schools, and provided close to 400 vaccinations for homebound residents. We also received 66 referrals from churches to Grace's primary care services. And lastly, I want to speak a little bit about our community pastoral outreach program. So it's been reported in a number of different media, the connection between faith and health, that there really is a linkage between a person's faith and their health. These are some of the things that have been shown, that there is a relationship between faith and health that encompasses various aspects of an individual's life. Spiritual health serves as a foundation for good physical health. That stress, faith, and health are really all connected. Studies have shown that people who attend worship services regularly tend to have more close friendships, which can in turn lead to better health outcomes. Faith, spirituality, and a sense of purpose all have a beneficial effect on one's emotional, physical, and mental health. And faith gives people a sense of meaning and purpose in life, which is often linked to better health. So we have a group of individuals, a nurse and some health educators who work on LifeBridge's community health and wellness teams. And they really serve as kind of a link between community members, some of these churches, for example, synagogues and other mosques and other places, and provide that link between community members and healthcare services. And some of the things that they do is provide linkages to access to health insurance or specific care providers. We know that there are over 3,500 religious organizations and congregations in the greater Baltimore metro area. More than 3/4 of the requests that we receive for community-based services comes from faith-based organization. And because of all this and really this context, we expanded our staff to include a community pastoral outreach coordinator. And some of the initiatives of that new role and of our community health educators includes Relaunch, which was a live webinar discussion on best practices to reopen church as well. So this is really during the COVID epidemic, when many churches and faith-based groups kind of closed down. A lot moved to online get-togethers. But this one in particular, the United Baptist Missionary Convention and Auxiliaries of the state of Maryland provided some education on how to reopen a church in a safe way. We also did work with the Open Church of Maryland on basically screening for certain chronic conditions, education on chronic conditions, and what to do to kind of avoid them or better manage them. And we've had an ongoing project with the Manna Bible Baptist Church, which is basically across the street from Sinai Hospital. And we've worked with them to on screenings for heart disease and hypertension. And these are some of the results from that effort. So in our Sinai and Grace community in West Baltimore, we've served close to 4,500 community members. In our Northwest Hospital area in Randallstown, over 1,000 community members have been served. And we've had 338 events held at faith-based locations, serving their surrounding community members as well as their congregations. And some of the things that we've done, as I mentioned, include risk assessments, healthcare screenings, and education on disease prevention and chronic disease management. And that's really my presentation. And I wanted to kind of take the opportunity now just to open up for any questions you may have. Let me stop sharing my screen. And I'd be happy to talk more. I'd also be happy to listen to any thoughts or suggestions you have or any work that you're doing in your community.
For questions, we have a chat box, and then if you raise your hand, I'll be able to allow you to speak as well.
Mark, go ahead. I think there you go.
Can you hear me?
Yep.
Hey, great presentation. I wonder if you could talk a little bit about sort of how your role interacts with the leadership of the various hospitals and coordinating these kinds of activities.
Sure. So my role really is across all of our hospitals. It's sort of a corporate role. So we work with the executive leadership of each hospital. And for programs like this, we actually, for our diabetes education and healthy food access program, it initially started out in the first year of the program as just a West Baltimore, 5 zip codes. We got some latitude later in the program, which is why you saw that uptick in our ability to kind of enroll more patients or enroll more people. And we were able to really expand it across all of our hospital service areas. I think our department, our very small department, is sort of seen as sort of the go-to in terms of the issues that are affecting hospital admissions or readmissions, that just to stay in the hospital doesn't really address. There's some ongoing issues in terms of either like access to food, low income, lack of access to normal sort of primary care services due to that, that lead to kind of poor health down the road.
Great, thanks. I guess for others that may be trying to implement similar activities, what kind of steps have you done to help leadership understand the importance of population health?
Yep. Yeah, so some of it is, looking at examples from other Maryland hospitals in terms of kind of their sort of this sort of healthy competition. So what they're doing and really why they're doing it, and bringing that to our executives and showing sort of the quantitative data behind that. So how that links to a reduction in readmissions and other things which our hospital is essentially graded on by the state. I think we're fortunate in another sense in that the Joint Commission, the Center for Medicaid and Medicare Services, and others and state regulatory bodies are increasingly requiring this type of community benefit support work. Increasingly, our role, in addition to supporting the community and their health, is to really help our hospitals meet those requirements. So, for example, we now every year report on what community benefit in a financial sort of dollar sense and a program outcome sense each hospital is doing in their service areas. So that's collection of data, and then really kind of supporting that and integrating some of the work done. We also have the lead role in administering or completing those community health needs assessments. And then an implementation plan, which is also required. So we're not just collecting information on what our community members say, but we're also showing that we have plans to work on improving specifically those areas. And we're really kind of aligning our work with our hospitals around those things. So we're not distracted by whatever happens to come across our desk, but actually really focused on, those priorities that we heard the community say.
Great, thanks for taking my questions. And again, thanks for a great presentation and really good examples of how to apply these population health management principles.
Great. And I saw in a question from Andrea, I think in the Q&A box, around mental health and some of our interventions there. We've done a number of things. So in relation to safety, we have a Center for Hope that's part of LifeBridge that works in Baltimore City and also Baltimore County, and provides really support to people who've been exposed to trauma, either due to neighborhood violence, personal violence, or abuse. We also have a new sort of open doors program where we place a community health worker, a trained community health worker, in some of our outpatient facilities, specifically to deal with those mental health issues and help make referrals and identify kind of what those issues are. So it's a big issue. It's also something that we are expanding our work on, and we're working closely with the city and county health departments to have a sort of a unified approach. One thing that, as a result of our work, of all of our hospitals work with the city and the county, there is now a sort of Central Maryland initiative where referrals can be made to a central organization. It used to be called GBRICS. It's now the Central Maryland, I think, Behavioral Access. It's basically a phone number that you can refer patients with mental health issues to, instead of relying on the police force or others that may be less equipped to kind of handle those issues. Other questions?
And we did have someone's hand raised and they put their hand down. So if you would still like to ask your question, please put your hand back up and I will surely unmute you. Okay. So we have Kelly. I'm going to allow them to chat and you should be
Thank
able to
you.
ask your question.
I put the question in the in the chat as well. So I work with primary care providers, and I run into a lot of resentment, um, because I think that my providers feel that population health management, specifically those things around social determinants of health, are not the responsibility of primary care to address. So I get a lot of pushback for screening or even implementing things like um, healthy food trucks, which we have in my organization as well. And I'm just wondering, besides providing data that shows that, interventions do help, how would how would you address that?
Yeah, it's a great question, and it's a tough one. Primary care providers in the community are typically overwhelmed with the work that they have now, and thinking about something, additional added to their plate can be very overwhelming. Um, I think I don't know that we've had the answer or have done it particularly well. One thing that we have done is been able to provide some resources to their offices, so they don't feel strapped for resources. So this is often a kind of a care coordinator role, sort of like a community health worker, that sort of has the role of working with clinicians in that clinic, to help identify, to kind of work with the patient and help identify any social determinants of health that that individual may be having or experiencing, and then helping to refer them to resources. So maybe it's limiting it then for the provider to maybe asking a couple of questions, or at least introducing the care coordinator to that particular
Mhm.
patient. Um, it also helps too if you have a medical director sort of overseeing the primary care providers, that can kind of raise this up and sort of explain why it's important. I think many primary care providers really understand the sort of the upstream aspect of this, but I think it does. I mean, as you suggest, it seems just overwhelming to think about trying to address that portions of people's lives.
Mhm.
But I think if you do have additional resources that can help, and if you have some concrete resources that you can provide these individuals, I think that's one step forward.
Thank you.
Other questions? Anyone want to share what they're doing at their organization, or concerns that they have? Okay. Well, I don't want to hold folks up. So if there are no questions, I think we can kind of wrap up today's session. And just again, want to thank you all for participating. It was great being able to talk with you. And feel free again to reach me offline, send me an email if you think of something, or just want to chat.
Thank you.
Thank
And
you.
thank you so much, Dr. Baker, for presenting today. It was a great session. I will make sure to email everyone who attended the recording of the session. So thank you so much again.
Bye-bye. Thanks, everyone.